So, good morning everybody. So today we are going to have a talk on liver transplant in Asia, the current scenario and the unmet need. So we will cover in following few minutes on these outlines. So to start with, the most important question is why liver transplant? The most important is the long-term outcome. So the transplant has happened because it is life-saving, gives a better quality of life and gives a improved outcome than the previous state. So transplant has been accepted as a therapy because it is one of the treatment successful for all spectrum of the liver disease when it fails completely. Outcome is increasing over years despite the high risk grafts has been considered and the sick patient has been taken. Long-term survival is mostly influenced or defined by the mortality, and this happens, the first mortality happens, the significant part is in the first year, and the mortality after 1 year is only 20%. So the causes of mortality in 2 to 5 years is malignancy, liver graft related infections, coronary heart disease and other complications, whereas after 5th year it is the CAD, few infections and malignancy, and the outcome is improved because of the good graft of the donor assessment, better surgical anesthetic microbiological care and improved use of immunosuppression of the rationality. And this transplant success is also across all the age groups. You can see here below above 45, then 18 to 40 and below 18, all shows close to 25 or survival is close to 50%. So that's why if it's taken at right time, the long-term outcome is good. So that is the global data. And if you give the Asian perspectives, in this study it shows that there is also patients of Asia, it behaves also similar to the global trends. The survival at 10 years is close to 71%. And the next most important is when you transplant is the quality of life. So quality of life is, you can see here, so this is a validated SF36 where it shows that when you consider the patients who are having previously the bar is for the life of quality with disease of the liver, that is CLD, then this is after transplant, and this is the normal population. So this is US data, and it shows that after transplant definitely the quality of life improves. However, only 50% able to return to their previous job, and despite having good term outcome, definitely better, but physical, emotional components still inferior. But however, this is the way forward we need to think of as a challenge in post-transplant setting, how the life should back to the normal, how they can lead a good quality of life. So as we see the transplant is successful, now we'll see how in Asia we are thinking of this transplant. So you can see this is the whole global data. The 2.4% mortality across the globe is related to cirrhosis, and over the time the liver disease prevalence is increasing, and also the transplant rate is also increasing from 6.5% and this is 20% increase in 2021, and mostly it is the DDLT across the western parts. And you can see here is a very interesting diagram for the country wise for the need of the transplant, where the Asian patients need highest liver transplant, because Southeast Asia had the largest number of death of cirrhosis in the world. The region were more compared with death rate, cirrhosis mortality in Southeast Asia was comparable, but the difference is because of the large liver disease burden and less transplants. And interestingly, the mortality in Asian patients with cirrhosis in absence transplant is less than the European or Eastern Mediterranean regions. It is, so that is a good food for thought that in Asia the treatment and outcome, despite having less available or affordable, the outcome is good. Only it is because of the number of patient loads, the highest liver related mortality is happening in Asian countries. And you can see the transplant across the globe is defined as the parts per million, transplant needed per million of populations. India is still on the lower zone of around 5%, whereas the other countries are making better, particularly USA and European countries particularly weak. So this is data on comparison of the live donor versus DDLT program. You can see across the all countries India has the transplant per million is close to 2.5, and that is mostly live donor, and cadaver is very small. As we can see here, the rest of the countries, particularly Spain, you can see USA, the cadaver is the robust, that is totally reverse trend. So in India or Asian countries, the most important is how to go for this. So this is the comparison of the over last 10 years how the transplant is happening across different countries, and you can see the India transplant related cadaver is close to 600 700 only, and these 2 years has dampened because of the COVID, and but still it is inferior in compared to other countries where the program is running well, and particularly the DDLT is inferior. That is good thought. Then as we saw that the liver transplant is a need, and transplant is LDLT mainly in our Asian parts, then what are the challenges how we can overcome, and what are the unmet needs? The first I want to say the delayed presentations. So this is a beautiful old study, but shows if a cirrhosis comes to you, how you predict them. So it is no decompensation, the median survival is close to 9 years. Any decompensation, it suddenly comes down to 2 years. SBP is less than 1 year, refractory ascites is 6 months, hepatic encephalopathy 1 year, HRC is weeks to months. And the varices, if compensated, 1 year mortality is only 3%. If presence of ascites, no bleed, 1 year mortality is close to 20%. If ascites and varicose bleed is happened, the 1 year mortality is close to 57%. So this is all from the natural history study of cirrhosis, which shows that how should be serious when a patient comes to us, how aggressively need to treat them, and how to think of. And everybody aware of this minimal listing criteria, and not going detail, but only thing that this is the parameters that child PUC 7 or above, GI bleed, single aid SBP, ascites if refractory encephalopathy, SCC, liver synthetic dysfunctions, and some other disease specific etiologies, they should be considered for the transplant, that is minimal listing criteria. So some others, I think everybody aware of these conditions, which are to be considered beyond mild except, that is mild exceptions. If we delay, the waiting is there, what happens? Sarcopenia and frailty increases over the time, disease severity increases, as AK, that is rightly presented by Dr. Rakhi, has a good paper on this, how cirrhotic patients progress with AK recurrent to CKD, SCC goes progressed, and they develop life-threatening complications, sepsis and bleed. And as we think of next is the financial aspect, the direct expenses of continued care is definitely there. Post-transplant prolonged care in a sicker cohort is another additional problem. Some may not make it to the transplant because of the waiting period suddenly deteriorate. And this direct and indirect cost, if you calculate, that will be more than the transplant if you go on the right time. So for this, the ASLD suggested that all patients should be considered for the transplant at the index presentations with any of these complications or mild is 50 and above. And potential liver transplant should be considered to be expedited when there is worsening renal dysfunction or there is rapid hepatic decompensations. And same is also suggested by the ESL. Their deferred should be transplant center with any of the complications, and but this is mostly where the cadaver program is running, because there is no guarantee on the cadaver when to get it. In the Asian context, this is a need from APASL, we can say, on the timing of transplant for our patients as per the Asian context of the treatments with LDLT into the focus. If then next important comes is the abstinence and sobriety. So as we know, liver disease related to alcohol is increasing over the time, and it is 21 of the compensated, 30% of SCC, and this is gradually increasing both as a compensated or decompensated cirrhosis. And these complications also one by one is adding up. If see particularly Indian scenario, our patients are too sick, their presentation is with significant liver failure, response to steroid is only 20%, and the mortality is close to 44%. So these patients having a severity of and outcome is poor when they have ascites, hepatic encephalopathy, high bilirubin, low albumin, and definitely all the parameters. So this suggests that our Asian or Indian patients with alcohol is a different cohort who may not survive long, and even the treatment which is still considered the only treatment is alcohol, they respond only 12%. So that how to manage this group of the patients. So the challenges in this patient is our patient is sick, steroid is response poor, more infection risk, LDLT is there, and at the same time emotional support is strong, and still liver transplant is an ethical dilemma, and we have still 6 months abstinence rules, which has been, now you can see all the data. The transplant related to alcohol is increasing after all etiologies, and this is showing that the global data. And if they go for the transplant with alcoholic hepatitis, the things we should think in the life, it is a life saving, it is having equivalent outcome, and recidivity is close to 25% or below. Hence, whether we should think of abstinence rule, post-LT recidivism, and also have to think of scarcity of donor and donor equipoise. Donor equipoise is the area where you have to see that the patient donor relation, emotion, and obligations to go for organ donations, and available and affordable the transplant. So these all things should be considered. So with this, we think of most another important is the post-LT recidivism. It is there, the patient survival is comparable if they do alcohol relapse. The graft survival is also comparable, and also the recidivism with alcoholic cirrhosis or recent alcohol intake. Suppose someone is having abstinence for more than 6 months, a alcoholic cirrhosis, or who is a alcoholic hepatitis recently admitted, there is no significant difference if consider recidivism. And this is the study, they shown that these peoples who have high MELD score, even 50% receive the steroids, 17% recidivism, but the survival is not much differ. So both of these suggest that how to go for a patient of alcohol, he comes to us. You can see that as per the ESL, they suggest the candidate selection for liver transplant in alcoholic cirrhosis should not be based only on the fixed period of abstinence, and similarly supported by ASLD, the selection of patients with AUD should not be based only on 6 months criteria alone. So now we have moved from the guidelines of abstinence now to case-based and case-based emotional components and other aspects for a transplant in a case of alcoholics. Then important is transplant oncology. So this is, we know this is SCC and the liver transplant. It's a busy slide, but you can see only one is Milano's criteria, UCCF criteria for the transplant, but rest are all proposed by the ASEAN, that is Honjo criteria, Tokyo, SA, Asan, Seoul, 500, Kyoto, Samsung. So ASEAN context, liver transplant for SCC is good area and has been considered with data from Asia how to manage. But the cholangiocarcinoma, this is another emerging indication for the transplant where the data from ASEAN context is very poor. But however, what of the studies available over the time from 2016, the treatment has shown a good survival, close to 5 survival is close to 50 to 60% in this group of patients. So in this patient selection, particularly if it's less than 3 centimeter lesion, and they have been, Mayo Clinic has given photodynamic therapy, and they have no extrahepatic disease. So most important is the patient selections, and they have a very good outcome, and particularly with transplant for the cholangiocarcinoma, which we need to get data from ASEAN prototypes. That is also an unmet need. Then another is colorectal carcinoma. The colorectal carcinoma with liver metastasis is one of the area where transplant is much more in Western countries because the colorectal carcinoma has higher prevalence, and there is ACCA guidelines 1. The trial has come in 19. So treatment is similar. The number of should be more than 10, less than 30% involvement, no extra hepatic lesions other than the colon and liver, and the disease remains stable for 1 year. And these are considered parameters. And when they have gone for the transplant, in case of colorectal carcinoma, the survival is pretty good. 5-year survival is 60%, and disease-free survival is less than 0, nil at 2 years. So this is all data from the Western, which also a need for these non-conventional indications for the liver transplant in the transplant oncology. The similar way, also the metastatic neuroendocrine tumors, where the Milan NET criteria has shown a good survival rate and a robust patient selection criteria, which I am not going to, but this is also a food for thought. So why I need to think of a transplant oncology? In 2020, the cancer in SCI is 169 per 1 lakh populations, and the most common cancers include lung, breast, and colorectal. So what we are discussing, colorectal metastasis is also increasing in our country and in Asian part. Cancer-related mortality, if you think of the highest three killers are the lung, liver, and stomach. So liver is still there. So liver and colon are the two cancers which are coming in the transplant oncology and which we need to consider as far as the future directions are concerned. Then next important is what we challenge get is the obese recipient. So if a person comes with obesity, we have options to offer transplant. Then how to go for, because they need a large liver, so we need a whole liver, that is DDLT. In absence of a DDLT, how to go for? So we go with low GRWR with inflow modulations, or we try to optimize the recipient by bariatric procedures, or we go for simultaneous bariatric surgeries to address this. And the emerging is the dual lobe. The patient gets donor, two donors for the transplant, one from the left and from the right lobe. So as we know, before transplant we can go for sleeve gastrectomy, Roux-en-Y, IGV. So these are there. During transplant is sleeve gastrectomy, gastroplasty has been done and is cost effective. And post LC is the most ideal one to go for, but if he is able to survive the before transplant, then we can think of, hence before transplant we need to optimize them. So this is a study from Max Sackett by Dr. Subhash Gupta group. Here they have shown that if the patient is obese more than 100 kg, is 56 patients. However, the outcome is not bad. The mortality is only 30 days mortality is only 2, and most important is that GRWR, you can see the GRWR is below 65, below 0.65 in 17 patients, but only mortality is 1, that is 5.9%. So this is shows that if you well manage this group of patients, you have a equivalent outcome despite having low GRWR and they are being morbid obese with traditional. But this is a more surgical and technically challenging, which need to be overcome over the time. Then another is what we thought of dual grafts. So dual grafts means two donors for a patient, that is one donor gives the right, another gives left. This is very technically challenging and limited data from India. Only one center in Mumbai they have done single, and this is most data is from ASEAN Korean centers. They have been 400 patients with ABO compatible graft, and they show that complications are little bit on the higher side. Operate time was longer, but transplant blood is more. But however, 10-year patient survival is 80%, so that is desirable. And to further complicate the issue, you may not get two persons having same blood group in the family, so ABO incompatible dual group graft. So one may be matching, another may be matching, not matching, and they have given to the 28 recipients, and they show that the fiber survival is close to 60%, and then survival of the graft is 92% at 5 years. So this is shows that how a technically challenging areas is upcoming for a obesity, and which is the likely to increase. The obesity is increasing, the liver cirrhosis, NASH related is going to increase, where the dual lobe graft is another technical marveling, you can say, is going to have help in future. Then next important, the challenge for us is multivisceral transplant. So as far as SLK is considered, most frequently we come with is simultaneous liver kidney transplant, and this simultaneous liver kidney transplant is how to go for. So till there's no established guidelines. However, in cadaver setting they get 2 points advance for the preferential organ to be received in cadaver donors, and the criteria I think SLK has not changed over the time. So but you can say CKD, sustained AKI, or having metabolic disease with a renal involvement who needs liver and kidney like hyperoxaluria or HUS. The next interesting concept is called as Indian approach. It is single center, where they have done the liver patients. When concept for the SLK, the patients are too sick to go for surgery both liver and kidney. So what they have done, these patients has been made transplant for the liver alone. They made to be stabilized. In another period of 3 to 4 days they go for the kidney. So that is in the same setting, but first liver patient get stabilized and then they go for the kidney transplants, and this shows that the graft loss has reduced and it is much less than the if you go for simultaneous combined liver kidney transplants, and long-term outcome is also better. So this is a single study, and now it has been started to be followed in mothers, and it is needs further replications. But I think this is a area where we can see here in ILBS, where we find these patients who are having both liver and kidney, where we are not thinking to go for simultaneous because the donor issues, or they have a issue of the patient being sick. Then next important is how to increase the donor pool. So donor pool to be increased, we can think of in two criteria, two scenarios in case of live donor or in cadaver donor. In live donor, as we think the low GWR patients, most of the time they being denied for a transplant, how we can go for them, ABO incompatible, a disco solid dual lobe, and also swap, which is now the paired exchange of the donors. In case of DDLT, we can consider B and C positive viral positive grafts, domino transplant, and deceased donor transplant, and the machine perfusion. So if you consider first the ABO incomplete transplant, this was started in 96, and now it is able to consider nearly 20% of the transplants to have a incompatible transplant, and the protocol is very simple now. No need of having any splenectomy or infusion. It is simply a rituximab plasma exchange along with immunosuppression manipulations. And here important thing that if you think of ABO incompatible transplant in cadaver setting or live donor setting, the cadaver setting results are little inferior because of time, urgency, and preparation of the recipient. And whereas in case of long-term survivals, we consider is having better in terms of LDLTs there. They are comparable. But we need patient selections. These studies with the predictors of poor outcome are being the advanced age, urgency of the transplant, higher MELD, prolonged ICU stay, and if they develop post-transplant infections, or we are going with a low GWR complication, low GWR for the transplant, or they develop biliary complications. So what before transplant we can think of age, urgency, high MELD, prolonged ICU stay, or having low GWR. So these are things pre-transplant we can select a patient whom we can think of to go for. So for ABO transplant we need to see the general condition, disease profile, and the transplant evaluation. That titer should be less than 16 and have at least to have a good GWR. So this is how this ABO incompatible transplant is going to increase the donor pools. The next important is donor weight loss. So this is study from our center only. So this is donors who are initially unfit because of having F1 fibrosis, and they are able to lose their weight by diet and exercise, has gone biopsy, and out of 13 they are able to go for the transplant as a donor with good outcome as far as the donor as well as the recipient is concerned. Only thing that is, as Dr. Pamit is here, they have shown that they have a little bit of higher bilirubin level immediate post-operative period compared to those having non-NASH donors. But still it is a good food for thought. I think now this number has increased, and we are seeing that the obese donors who are otherwise fit, they can be proper protocolized care can be taken for the transplant. Then if you consider the donor swipe is, this is the one, the donor change exchanges as per the blood groups when these two pairs are there, and this is recently one from the Indian publication where 3 groups has been exchanged, so that here this able to increase the number of organs that can be used, donor pool can be increased. Then you think of in DDLT scenario how to go for. So already we know the marginal grafts like elderly graft, steatotic graft, deceased donors, hepatitis C, you take split glass, livers sometimes when refused by many others. So these are the conditions where the graft has been taken as a marginal graft or extended criteria for the donors. Then when consider this concept of DCD or non-taking, there comes the organ perfusion. So why we need, this is the branded, will come later the DCD. What happens if there is organ which needs preservation, then recipient and implantations. This is the deceased donor. Here they get a ischemia. And this ischemia is the major risk factor for the DCD patients because the cardiac death happens, body has ischemia started, and this leads. And the journey of a transplant cascade is war ischemia time 1, then cold ischemia time, war ischemia time 2, and the reperfusion injury as the selection of the blood flow blockage and then reperfusion is concerned when we retrieve an organ and implant an organ for the transplant. So commonly we need a perfusion so that gives a organ support to the organ, and these are the various few molecules. You can see the important molecules: buffers, free radical scavengers, and nutrients. So all are mixed with these solutions to give liver a homogeneous medium through stable. And this is a normal metabolism of an graft, and this is what happens when ischemia is there. They have a high potassium, high sodium, low potassium, high lactate, and they have been dehydrated. And this is shows need a area to correct the physiology what they are should be before or in a normal metabolism. So this is needs the reperfusion solutions. And when consider comparison of the preservative methods, you can see the common solution we use. Then this is the standard solutions, and how we can make dynamic preservation. That's normothermic machine perfusion, supernormal, and hypothermic normal perfusion. Hypothermic machine perfusion. You can see the temperature. So static cold storage, what we usually do organ whenever comes to us is a bucket which is 0 to 4 degree temperature. Then now this machine reperfusion has revolutionized the organ transport and organ quality, and there are various devices which I am not going to detail are available for this. And this is the oxygenator, then a pump, there is a reservoir, and then this lever has remained in a surrounding to go for. And this is the now a dynamic trolley which goes with organ being kept here. They get all support from the all around so that the long term can be used. And recently the hypothermic machine perfusion, which is this is the graft which get a portal vein perfusion, hepatic artery perfusion, and the solution is up in low temperature, and then it is collected also outside the perfusate. So this is able to preserve this in a balanced temperature, balanced flow, both vascular to keep this. So as we saw that the organ we are able to support for a long time. Then comes next as we discussed, organ no one wants to take or is liver. So now from animal, now it is come to the in vivo, the how we can able to deep fat them. The deep fat strategies are there, the mostly because this extended carotid liver donors are age, steatosis, increase cold ischemia time, and there if disease, the chance of ENF or graft dysfunction is on the higher side. They have a steatosis close to 60%, and this will cause more problems. And steatosis is, if it is more than 30%, mostly they get discarded in nearly half. So now if there is any method we can able to remove the fat from the liver. So the basic mechanism of the liver fat deposit has been taken the reverse way to defat them, to remove triglycerides. Then we have to oxidation to prevent lipogenesis to block, and both at the level of membrane, then lipolysis, oxidation, mitochondria, endoplasmic reticulum, and the nucleus. So at all level these drugs are in various level trials so that the liver fat can come down. And this is last year Nature paper where they have given normal machine perfusion which can able to keep a graft for 7 days in an artificial solutions, and they have seen that this graft is able to reduce the fat and can be considered for a liver transplant. So this is the food for thought to go for. So this is the machine where they are able to keep this liver and defat them. That is called as the liver repair. So these are the studies I have shown. These are the my studies. Now these are the one liver which are discarded has been considered for the defatting. So the future of liver transplant with machine perfusion, this is what we are. The cold perfusion, cold storage to go for transplant. Then now comes is normothermic regional perfusion or cold perfusion, and this is normal or hypothermic. And then now it has been added that we can go for the repair, organ repair, that is defatting. So this is going to increase our organ pool for transplant. Then why we are thinking of a DCD? You can see DCD means donor after cardiac death. What we are considered till now is donor after brain death, and this is, as we know, we go through circles and our cases are on the accordingly. But most of the patients what we see goes for the cardiac death or ischemia or cardiac arrest, so they can add another pool, and for this doesn't require full criteria of a brain donor should be there, and non-recovery injury or illness is not there. Depends on life sustaining therapy already they are. Decision to withdraw of life sustaining therapy should be decided, and expectation of imminent death following withdrawal of life support therapy has to be anticipated. And assessment here is not brain death, it is the apnea and circulatory arrest. And stand-up period is when circulatory arrest has been achieved, which is earlier than expected brain death. Hence, this is mostly can help. And the DCD when is called controlled, that means you are planned or uncontrolled, and protocolless care, the outcome is now getting better, close to 5-year survival, 25-year survival, few grafts. It is from European study, close to 25%, but it is comparable both DBD as well as DCD in long term. And this is the whole Europe data mainly on DCD, and is gradually increasing from 1210, and now it is increasing gradually. So we know the brainstem, we know the circulatory arrest. As I told, it is controlled or it is uncontrolled, that is sudden, unexpected. But however, this can able to address, because this group of populations with us is on the larger number than this group, that is DBD. And this can be by a robust organ donation program, and DCD options we can able to explore, and if can consider organ perfusion or organ repair strategies, we can get more organs to be used, and DCD liver transplant may be in the future able to address this organ donor crisis in Asian countries or the India. Then next is how to expand donor pool is a strategy for a robust transplant program. This is a big topic I am not going to address, but this is needs a collaborative approach from the all aspect, policy to social to hospital perspectives. And then in absence till now, how we can go? LDLT is the immediate solution, as today I am dead, because liver transplant started in Asia first. It is first the DDLT. However, DDLT is not able to pick up, and LDLT is there because of confusion related to various legalities in brain death, mistrust among the clinicians and general public, and diverse governmental and social hierarchy, and lack of religious and cultural uniformity for this noble cause. Hence, we have having more reliance on LDLT, but this barrier to be broken. You can see this is the whole world data on organ donation, where India is only 0.4%. But if you go to the survey, you can see India is in the top country where people 74% are willing to donate organ. So there is some lack. We have more awareness. We are now has improved, willing to go for the organ donation, but still we are not able to increase. So that means it is a more at a policy level than this. And to example how we can help is the Turkish model. What they have done amendments from the religious heads, then government organization to monitor them, and they have done extensive information education communication IEC activities, and this leads the organ production 0.9 per million to 7 per million in period of 18 years. So if we thought of this way, we can think from now, it can be a big help how to go for. Then important, what is need in Asia is the liver transplant tourism. So liver transplant tourism can happen, donor recipient both comes to another place. That is what we are seeing from here. Our donor is going to some recipient country, or recipient is going to the donor country, or both are in a different countries, and others is the domestic country, the different part. So this is how happening. The one is what we get, and the other last 5 what we get, that they come from center or place where in the same territory, but transplant is not available. So transplant tourism is happening this, and if you see the cost of the transplant in India is much cheaper than this, and at the same time the medical tourism India is in the third. So this is where the liver transplant in India or Asian countries can be a big boost, and this is to show that Turkey is now till the on liver and nephrology is the most destination for the transplant tourism. And the cost of an average transplant 2.5 share in US, 1.5 share in Singapore is only 20 lakhs in India. So this is where the Asian countries can be a global destination as per transplant tourism is concerned. Then if you address all the issues, now how to go for on the translational research as far as transplant is concerned, that is most important burden is the immunosuppression. So can we make them immunosuppression free, that is development of tolerance. And how we can decrease our immunosuppression, this is innovative concept of bone marrow transplant. If you are able to do a bone marrow transplant, likely you may be able to, a reducer can stop the transplant. Related immunosuppressions. Xenotransplant has come up. We have seen one peak transplant which for the heart, which may come in robust way in future. Artificial liver, what our center is working on. Hopefully we can think of the bridging therapy, FMT and cell-based therapy are there. They need more replications, more use in wider, particularly not in the research domain to the hospitals. If that we can make, that also can address. So this is all we need this way. So to summarize my talk, the liver transplant is an burning in Asian particularly and also Indian. And if you make a strategy, we need to address the delayed presentation of a patient to us or a delayed referral for the transplant. Alcohol recidivism or sobriety should be considered based upon the clinical socio-economic profile rather than the strict rules. Obesity is now, it is increasing, which we should address by low GIWR, dual lobe transplant or aggressive care with handling a low GIWR or pre-transplant optimization of weight by intragastric balloon or sleeve gastrectomy or simultaneous. Then non-conventional indications has to be explored, that is particular one area is a transplant oncology and mild exception areas where we should take them. If you consider DDLT scenario, we need to more consider for the extended criteria, and that is needs to be support from organ perfusion, machine perfusion and other robust techniques. And DCD has to be formulated in Asian or Indian country first how to go for. If you consider LDLT scenario, ABO incompatibility, particularly we should think of early rather than having when a high MELD child C or being frail. So these patients can be salvaged if they won't have a potential donor by early with a low MELD ABO incompatible transplants. Donor optimization, as we saw that donors can be considered. I think I'm sorry, I forgot that one paper now has come up. These donors, when they go for optimization with the exercise, they have a better regeneration of the liver in the recipient and the donor. So these are the few help areas. Swapping also another area that need more legal as well as more logistic clearance to be considered. And liver transplant techniques, I have not covered much with surgical domain, but I can say the dual lobe, laparoscopic or robotic surgery and surgical techniques has to be more and more improved. That is Asia, particularly Korea, Singapore and China are the peak and the technical innovations, which India also now joined that club. I think that will going to address, but we need more refined and more important. And next important is how transplant can be affordable through different programs, how it can be available at most of the centers, and if not, then transplant tourism should be promoted. So this is, I think I have to consider. Thank you.